Dr. Mehvish bhatti, and I'm ENT head and neck surgeon, and I have joined AKHSP for Gilgit Medical Center as an ENT head and neck surgeon. So today I had been invited to discuss the most important topic, that is the tracheostomy. Since it is related to the airway, so that it is the most important topic to discuss and to get to know about it, and about the complications as well, and so far the post-operative management is concerned. So I would start my presentation with this quote that love someone with a trach. The reason is we have no idea what the patient on trach is up to, and how he is suffering, and what complications he is going to face, so that we are supposed to love them and we are supposed to have empathy for them rather than sympathy. But what I have noticed that the patient on trach usually gets sympathy. This is not the actual correct thing. We are supposed to have empathy for them. So definitely it's a procedure, surgical procedure, and I'm going to discuss the indication first. The first and the most important indication is respiratory obstruction. As we all know that tracheostomy, like we are going to make or create a stoma in the trachea, and we're going to provide alternate pathway for the breathing, so that anything that leads to the obstruction above the trachea, that actually means the upper airway and the respiratory obstruction, this is the indication for the tracheostomy. We have to go for the tracheostomy in order to bypass that obstruction to relieve the patient from the respiratory insufficiency. Then tracheostomy can be done in the patients with the where we want to prevent them from the aspiration. That may be secretions, that may be the blood. Especially here I would mention that especially the patient with comatose patients and the neurotrauma patients, and the patients actually who had RTA and the mid-facial trauma patients, where there are more chances of aspiration of the blood in the airway. So that you will not wait for the ETT in those patients, because eventually you have to do tracheostomy in such patients. So tracheostomy is the eventually the first line of intervention that is supposed to be done in such patients. Then indication if you cannot intubate the patient. But now it's been said there is a one concept that is called KICO, capital C, capital I, capital C, capital O. KICO means like you cannot intubate, you cannot oxygenate the patient. In such patients, they said that you have to go for the tracheostomy, but now it's been replaced as another thing that called as the crash tracheostomy. Crash tracheostomy is actually, it is the type of the cricothyroidotomy, but that is only the means of the scalpel and the chisel. Like you do not have to wait for the apparatus proper जो crico का होता है. You have to put tube eventually in those patients by means of scalpel and chisel. Then if you cannot intubate the patient, there is some contraindication. Like there are many cases in which you cannot intubate the patient, like the patient who has the cervical spine trauma. It's been said that you cannot even do tracheostomy in such patients, but we can do. Like you have to avoid hyperextension of the neck, but for intubation you have to hyperextend the neck. But for tracheostomy, you can softly extend the neck and you can perform procedure in such patients. So if there is a failed ETT, then you have to go for the tracheostomy. And then definitely if the patient with GCS 8 or below, that is usually considered to be the indication for the intubation. Then in some patients, we also may need the tracheostomy to basically remove and to get rid of the retained secretions. How? Because when we pass the tube, then definitely we are directly interconnect with the lower airway, and when we can also remove the retained secretions in the lung by means of tracheostomy, by means of suctioning. So these patients are usually the patient or the children with bronchiectasis and the pulmonary abscess, and the pulmonary TB patients even. Then tracheostomy is also being done to administer anesthesia. Administer anesthesia actually means like when the patient has difficult intubation or the limited mouth opening. Like in many patients, in case of the maxillofacial, in TMJ ankylosis, you cannot intubate those patients. You have to perform tracheostomy prophylactically. And in patients, like once we have those patients like laryngeal growth, we cannot intubate them. Supraglottic will be all, it's covered by the growth. You cannot pass tube in those patients. Then you have to do direct laryngoscopy and you have to take biopsy. So you have to administer anesthesia by means of tracheostomy tube. Then again, if your patient required intermittent positive pressure ventilation for the prolonged period, for the prolonged time period actually means when your patients required ventilatory support for more than 72 hours, you are supposed to convert into the tracheostomy in order to prevent the patient from the complication, that is the subglottic stenosis. But in children's, it's another concept. Like in children's, you have to wait for the 2 weeks, but in adult patients and old age, you have to perform tracheostomy in more than 72 hours. Then I have already discussed the contraindications of the ETT and the midfacial traumas. Then respiratory insufficiency. This is the most important thing. Like people consider it, if we have the patient with the pneumonia and the pulmonary abscess and the effusion and all that, then how tracheostomy is going to relieve respiratory insufficiency, that is related to the lungs actually. So related to the lung, it has 3 mechanisms. Number 1, it is going to improve the alveolar ventilation. How? It is going to improve alveolar ventilation in 2 ways. Number 1 is there is a dead space, as we all know, and it basically reduces the dead space, and it is actually reduces the resistance of the lower airway as well, so that it even improves the respiratory insufficiency that is related to the lungs as well. So these are the patients with diffuse pneumonia, or you may say the lobar collapse, जो basically patients होते हैं, उनमें we can do that. Then as a part of the another surgical procedure, is when you know that the procedure you are going to perform, the patient has, you can say that basically patient is going to have aspiration later on, and you know that patient would have impending airway obstruction. Like if you are operating huge thyroid and you are supposed to get prepared for the tracheostomy, and you are supposed to take in consent in those patients pre-operatively. The reason is you never know that if you are operating over the trachea and you have to remove the thyroid gland, then the patient may end up with a tracheomalacia. You have to put tube in those patients. If you are operating the patient with the skull base or the floor of the mouth and the oropharynx, any procedure that is related to the oropharynx, floor of the mouth, skull base, and you know that patient will lead to the impending airway obstruction, or the patient would have aspiration, you are supposed to perform is in conjunction with the another surgical procedure. So after the indication, I would like to explain the surgical procedure. So tracheostomy is basically divided into the 2 types. One is the emergency tracheostomy, then we have the elective tracheostomy. Emergency tracheostomy, as the name indicates, that you have to do this to maintain the airway in such patients who cannot maintain oxygen saturation. While elective tracheostomy, other than airway obstruction, all indications come under the category of the elective tracheostomy. So it is done under the local anesthetic agent, and it's been done under the GA as well. So the patient who has already intubated, in those patients, we can give them GA, and then we can convert ETT or the intubation into the tracheostomy. But in emergency patient, you cannot do that usually. So you have to perform tracheostomy under local anesthesia. So then definitely the position is mandatory, very important. The position is supposed to be the supine position, and head is supposed to be the extended, so that the sandbag is supposed to be put inside the patient's shoulder. Hyperextension is need to be avoided. When we performing the tracheostomy in children, then what we need to care of it, that you have to stabilize the patient head as well, and you have to avoid hyperextension of the neck. Because in children, what will happen is the chest contents come out to the neck basically, due to the natural defects in the body basically, so that you may damage the lung pleural apex actually. So you have to take care of the position of the patient as well. So after position, definitely prep and wrap is done. Then after prep and wrap, incision is mandatory. Usually 2.5 centimeter incision is sufficient. And incision is in horizontal. Incision can be given in horizontal direction, in vertical direction as well. So most of the time it's been recommended that horizontal incision is done because it has a good cosmetic effect. But in emergency tracheostomy and in children, it's been recommended that we are supposed to go for the vertical incision. The reason is, due to the vertical incision, you do not get laterally, you remain centrally, so that the focus is the trachea and you do not deviate yourself actually or distract yourself. But it has a poor cosmetic effect. Incision is given usually 2 fingers or the 1.5 fingers from the thyroid cartilage, like below the thyroid cartilage and above the suprasternal notch. After the incision, and you have to dissect the soft tissue, and after soft tissue dissection you encounter the strap muscles here. You are not supposed to release strap muscles, rather you can retract them laterally, vertically. After these strap muscles, you may encounter tracheal fascia, but before entering into the trachea, you have to remove the tracheal fascia, because if you do not remove the tracheal fascia in those patients, if you directly perform the stoma, then the trachea gets deviated under the coverage of the fascia, and you may miss the trachea during the tube insertion, and you may put tube in the soft tissue or the under the tracheal facial cover, and tube may dislodge or displace. So tracheal fascia incision is very much important. After the tracheal incision, tracheal fascia incision, what we should do that, then you have to put a tube in the stoma. You have to create a stoma in the trachea. But before creating a stoma in trachea, what we need to do is we have to put one needle with the 2 cc or the half cc basically saline, so that you may confirm the presence of the trachea. Whenever you pull the plunger of the syringe, there will be the air bubble inside it. So once the trachea is confirmed, what you can do is just put little 2% xylocaine to inhibit the reflexes or the cough reflex in those patients. And after the putting xylocaine half cc, then you can create a stoma. Ideally, the stoma is supposed to be done in a third and fourth tracheal ring. In children, in adults, both. When you create the stoma, there are different techniques, or you may say the practice of the surgeon, that how you are going to do the how you are going to create a stoma. But in children, it's been recommended, initially it was recommended that you are supposed to retain the flap, like you perform U-shaped stoma, and then you take one stay suture by means of proline, and you put that flap upward, and put below that, put your tube inside it. But now they said that flap basically, retained flap leads to the tracheal stenosis. So we are not supposed to retain flap in children's even. Just give vertical incision and put your tube inside. And in adults, you can give a vertical incision, you can give U-shaped incision, and a square incision, and circular incision, and even crocheted incision, like plus sign. It can be given in those patients. So it's all depends upon that how you are basically comfortable with the incision. One thing I have missed in the procedure is that when we retract or strap muscles laterally, we usually encounter thyroid isthmus in the patients. So for thyroid isthmus, what we can do is sometimes it's so huge that it covers the whole of the tracheal ring, because we never know when we are performing emergency tracheostomy. We don't know, patient may have the coexistent pathology of the thyroid as well. So in those patients, you encountered severe hemorrhage because you directly damage to the thyroid isthmus. So in those cases, what we can do is you can retract thyroid isthmus upward laterally, and you can also retract it by means of the Babcock forcep as well. And if you cannot do that, and if it is under the surgical field, what else you can do is you can transfix thyroid isthmus as well. So after putting the tracheostomy tube, and its presence should be confirmed, and anesthetic is supposed to be beside you, and you should ask him to confirm. There are different ways to confirm the presence of the trachea or tracheostomy tube, or you can say the normal position of the tracheostomy tube. One is that both lungs should be basically, you can say the chest movement should be the bilateral and the equal. Then by means of the auscultation, there should be the equal entry in the bilateral lung fields. Then if the patient is on intubation, you can ask anesthetic to check for the tidal volume. These are the clinical parameters to check the presence of the tracheostomy tube. But there should be evidence, and you can say that basically you're supposed to have proper documentation that your procedure is rightly done, so that you can advise patient. Rather, I would suggest always advise patient post-operatively chest X-ray. This is going to help surgeon. Always think for yourself as well. This is going to save you, because chest X-ray is going to give you idea about the presence of the tracheostomy tube. Because sometimes you do not put the tube in the proper position, and it is usually inclined towards the right side. Sometimes in that case, only unilateral lung will be ventilated, and it will not be noticeable immediately. It will take time. Patient later will undergo to the subcutaneous emphysema and the lung collapse. So chest X-ray is very mandatory, because it's going to give you the idea and the guideline that tracheostomy tube is in proper position. So this was the written content for this, but I have discussed already, I think. Then definitely appropriate size tracheostomy tube. Yes. What is the actual size for the tracheostomy tube? There is no formula for it, but what I follow usually, we have the formula for the ETT. That is age in years plus 4 divided by 4. We all know that. So the tracheostomy tube is in ETT basically. Tracheostomy tube is usually 0.5 centimeters or 0.5 size less than ETT. So this is the roughly idea what I take into the consider when I have to ask patient for the exact size of the tracheostomy tube. Then closure. I was looking for some quotes basically, but I found this very good names, because most of my colleagues will conflict to me. बट ये वो वाली बात है कि आग लगी है बस्ती में और साथी जो है वो मस्ती में. The reason is my fellow colleagues think that tracheostomy is very easy procedure, especially general surgeons basically. They think that what you have to do, you have to just create stoma and you have to put tube inside. So you never know, ऐसे आग बस्ती में भी लग सकती है. Tracheostomy sometimes, I mean, it can sick your mind basically. You never know where you end up with the procedure, because it is related to the airway. Your patient may die with your any of the negligence. So tracheostomy is full of complications. So please do not say there is no complication in tracheostomy, and do not say this that the tracheostomy is very easy. It is sometimes, but sometimes it's very difficult. Then complications. Complications, as we all know that surgical procedures are full of complications. And complications may related to anesthesia, and complications may related to the surgery or the surgeon. So usually I divide complications into the immediate and post-operatively. Post-op, early and late. So immediate complication, we can start from the incision. What I actually remember it, you can give wrong incision. This can be the first complication. Then after that, if you are using, if you are roughly manipulating the muscles, you may encounter hemorrhage from the muscle. You may encounter hemorrhage from the basically skin side, incision side. You may encounter hemorrhage from the thyroid isthmus. And you may encounter hemorrhage from the tracheal fascia. You may encounter hemorrhage from the anterior jugular vein sometimes, and you may encounter the severe hemorrhage sometimes, aberrant innominate artery. That is the most lethal complication. So hemorrhage, this is the common complication in every surgical procedure. So for hemorrhage in tracheostomy, it can be managed in a similar way, but we do in other surgical procedures, like we can cauterize, we can ligate, we can transfix thyroid isthmus, and it can be controlled easily. Then apnea. This is the usually complication encountered, that if the patient has prolonged respiratory obstruction, what happens is patient has chronically hypoxia, and hypercapnia and the increased concentration of the carbon dioxide. So whenever you perform tracheostomy in such patient, what happens is there is a sudden washout of the carbon dioxide. So due to the sudden wash of the carbon dioxide, there is a decreased concentration of the carbon dioxide in the body, and it ultimately depresses the respiratory center. You have to put tube inside, but your patient is not improving, and you are thinking that you have done something wrong, but you haven't done something wrong. It is due to the decreased concentration of the carbon dioxide. What you are supposed to do is put your finger on the stoma. Release. Put your finger and release, so that the carbon dioxide and oxygen concentration gets balanced. Then pneumothorax. Pneumothorax, if you are away from your surgical site, like if you are working below, and if your patient is in abruptly respiratory obstruction and continuously breathing, because the pleural apex of the lung basically goes upward. So if you are working blindly, you may damage the apex of the pleura, and I have seen it literally. People have done it doing tracheostomy. The patient may end up with a chest tube as well. So this is a very lethal complication. Then if you are working other than your surgical field or the laterally and bluntly, and so you may damage a carotid sheath, and if you are creating a stoma, especially in cases of the children, you may damage to the esophagus, because it is very closely related to the trachea, especially in children. So you have to be very careful. And if you encountered a great vessel, you may end up with the air embolism as well. Then post-operatively, we may have the early complications that is due to the accidental extubation. We usually get calls from the ICU patient, basically, that the patient has been extubated and patient cannot maintain tidal volume. So the reason for the accidental extubation is usually in ICU patients, proper size of the tracheostomy tube is not used. Tracheostomy tube is not secure in the proper position, and they basically they do not use ETT adapter to the tracheostomy tube, basically, because we do not put Shillies in every patient. Patient cannot afford it. We usually put plastic tube. For the plastic tube, you have to secure the ventilatory support with it. Then displacement of the tube. Displacement of the tube is usually occur if you have put a tube in a soft tissue, and if you have used a small size of the tracheostomy tube, and if your patient has very much respiratory effort, this may also end up with a displacement of the tube. Then subcutaneous emphysema, then local wound infection, and tracheitis. Tracheitis is basically if proper wound hygiene or the wound care is not given to the patient, then the patient may end up from the local wound infection to the tracheitis, because the most common organism is the staph. Then blocked tube. Blocked tube actually means due to the secretions or crusting or the blood. These are the usually late complications. In late complications, we may have the hemorrhage that is called as the innominate artery fistula. It usually happens with the patient with prolonged tracheostomy tube, and usually the patients with metallic tracheostomy tubes, because it causes the crusting or the basically erosion of the blood vessels or the structure adjacent to it, so that the patient may encounter the severe hemorrhage, and that severe hemorrhage is due to the innominate artery fistula. Then a patient may have the tracheal ulceration that may lead to the tracheal stenosis. Then patient may develop the tracheoesophageal fistula if you have used a long tracheostomy tube. This is the reason that proper size tracheostomy tube is very mandatory. If you are going to use long size tube, it will impinge and it will damage to the esophagus, and if it's for the prolonged duration, patient may end up with a tracheoesophageal fistula. Then patient may develop the tracheocutaneous fistula and corrosion of the tube. Corrosion of the tube usually occurs in metallic tubes, and these tubes also may fracture, especially when patient is doing some effort. Like I have encountered one patient, like he was performing namaz, and he may end up with the fracture of the tracheostomy tube in the lung, basically. And then we have the problem with decannulation. The most important reason for the decannulation is psychologically dependence, especially in cases of the children. You have to decannulate the patient or the children under GA. Because child won't let you, वो ऐसे हाथ रख लेता है, नहीं निकालो सांस नहीं आएगा, लिटरली बच्चों के ये वर्ड्स होते हैं, नहीं निकालो सांस नहीं आएगा. तो बच्चों को हमेशा decannulate under GA करना चाहिए. Or when I'm talking about the adult patients, so there is a protocol for the decannulation, and the protocol is first downsize your tube always in such patients. Downsize your tube, downsize the tube. Then what you can do is admit the patient for 2 days actually in order to monitor such patients. And before removing the tracheostomy tube, always advise patient chest X-ray, ABGs, and always examine patient, and always ask ENT consultant to examine under endoscope. This is very mandatory because we never know that the patient may have the tracheal ulceration and the stenosis below the site of the stoma. So always basically rule out the pathology that will lead to the basically you can say that the impending airway obstruction after removing of the tracheostomy tube. Then admit the patient for the 2 days. First, always block the tracheostomy tube for 8 hours and observe the patient. And first, block the tracheostomy tube in daytime. Never block tracheostomy tube in night time because your patient may die due to this negligence. Then, if patient tolerate for 8 hours blockage of the tube, then do it for 12 hours. Then do it for 24 hours. If your patient is well, doing all the physical activities while the tube blockage for 24 hours or the 48 to 72 hours, then you can remove the patient, remove the tracheostomy tube. Then granulation tissue formation. Granulation tissue formation is usually in the plastic tubes. Basically, especially our medical officers, those who are on calls and performing duties, they are very afraid of the tracheostomy patients, that how I'm going to manage and how I'm going to take care of these patients. So it's not as scary until unless you don't know that what you have to do with those patients. So the post-operative care is very much important. First most important thing is there should be the constant supervision of these patients. There should be the always one attendant with the patient. There should be the always you can say that extra tracheostomy tubes should be present at the bedside. Then daily dressing should be done in those patients, and there should be the gentle suctioning. Gentle suctioning because overzealous suctioning may lead to the ulceration of the mucosa and the patient would have the hemorrhage. So gentle suctioning actually means that use the soft suction tubes like you can use Foley's catheter 14 or 16 number wala, or if you are using the plastic catheter, then we are supposed to teach the attendants that how to do the suctioning in those patients. Like when you are putting it inside, what you have to do is you have to put your finger on the right side of the suction, and you have to remove the finger when you are actually removing the suction. Basically, this is the proper way to do suctioning in those patients. And prevention of the crusting, because this will lead to the tube blockage. How we can do that? We can use normal suctioning. Then what we can use hypertonic saline in such patients, sterilized hypertonic. And hypertonics, I do not mean 0.9% wala, I mean 0.45%. Then we can use ringer lactate, and what I prefer is basically N-acetylcysteine. N-acetylcysteine comes with the mucolator sachet, and it comes with the capsules as well. And what I do is that 10 ml hypertonic via normal saline, and put mucolator sachet, one sachet in it, and keep it over the bedside, and ask attendant to do the suctioning by means of basically N-acetylcysteine, because this is going to prevent the crusting, and it will also decrease the tracheal secretions post-operatively. Then we usually put cuff tracheostomy tube in early stoma patients. So cuff is supposed to be deflated every 2 hours for 15 minutes in order to prevent the ischemia over the trachea. Then a change tube is supposed to be done after 3 days in adults and 7 days in children, so that the trach may form completely. Otherwise, if we change tube early, we may miss the stoma. Then a good antibiotic coverage is supposed to be given in those patients, especially that gives to coverage to the staph aureus. This is the very easy and usually the post-operative care that is supposed to be given to tracheostomy patients. And we should know about it, and we should teach our juniors about it, that how to take care of tracheostomy patients. So this is a very good quote, that trach life, you do not leave it, you won't understand it. And literally, because we have no idea what they are suffering. They cannot talk, they cannot respirate by themselves, they cannot communicate, they are dependent on others for suctioning. Patients cannot do their own suctioning. We have some facilities to heat exchange moisture, but they may end up with the crusting or dryness of the lower airway. They cannot smell. So there are various complications what patient encounter. So always have empathy for those patients and take care of them, please. Thank you.
Presentation.